Stroke is a major driver of disability globally. Women with migraines and the kind of migraines that give you warning signs before you get the headache are at an increased risk of getting strokes. Air pollution contributes to strokes.
How do you prevent stroke? Hello and welcome to the Own Your Health podcast. My name is Dr. Linda Biomdo and today we'll be talking about strokes. On set today we are hosting the one and only Dr. Jamil Alaarik. He is a consultant neurologist, an educator, and he's also a colleague at the unpack Neuro consortium. We will try to tackle all the most relevant questions that you've sent. I am so happy and excited to host Dr. Jamil. Thank you so much for attending this podcast today. How are you, Dr. Jamil?
I'm fine, yeah. Thank you, Dr. Biomdo, for having me here today. I'm honored and really excited to be here.
I think we'll dive to the questions. What is a stroke?
Yeah, that's a good question. So a stroke is when the blood supply to the brain is interrupted for either one out of two reasons. Either you have a clot that is blocking the blood supply to a specific area of the brain, or that artery that supplies blood to the brain gets it busts, and you have what we call a hemorrhagic stroke or a bleeding stroke. So those are the two main types of stroke, and regardless of the type of stroke, a stroke usually is when an area of the brain dies out because it's not getting blood supply, it's not getting the oxygen that it's supposed to get.
What are the earliest signs of stroke that you think, as an expert, everyone should know?
Yeah, that's a very good question as well, because one of the things that we struggle with is getting patients to come to care early. So many people miss out on the early signs, and that's extremely important because patients miss out on very critical treatment and timely treatment. So some of the early signs is sudden onset stuttering, sudden onset loss of speech, someone getting a headache that they've never experienced before, feeling dizzy and unsteady, like you've lost your sense of balance, deviation of the mouth to one side. So some patients would tell us, oh, I woke up in the morning and when I was brushing my teeth, saliva would ooze out from one side of the face. And then when I looked in the mirror, my mouth deviated to one side. So that's also one of the signs of stroke. Or when you feel like your arm is drifting, you know, you can't lift one arm, but you can lift the other arm. Or when you try to lift one arm, it just drifts. That also could be a sign of stroke. And initially when stroke hits a person, they usually have maintained consciousness and they're lucid for some minutes to hours before they gradually deteriorate. However, there are those who wake up in the morning and they just realize one side is not working. Their mouth has deviated to one side, or they're unable to talk. And this is what we call a wake-up stroke. And it's the relatives who find them on the floor, weak and unable to walk, and bring them to the hospital. Yeah, so those are the common signs of stroke.
And I think from the way Doc has explained it, most recently we've had the Kenyan public figure, Maya, who is a Kenyan singer. She says that she was just seated at her home, she was holding a baby, they were watching the TV, and then all of a sudden she just lost control and balance. She dropped the baby on the floor, she fell on the floor too, she lost balance and symmetry, like I think that is what you were talking about. She experienced weakness on one side of her body. I think it was a textbook picture, just how you're saying, she had drooling of saliva from one side of her face. And luckily she had people to take her to hospital immediately, which drives me to the next question. How quickly should people act when they suspect that they're experiencing a stroke, and not just the people experiencing the stroke, but also the family or the people around the person? If they feel like there's someone who's experienced a stroke, how quickly should they respond? And also in relation to that, should they just take the person to hospital, or do they need to call for an ambulance?
Yeah, that's a very good question. So time is of the essence when it comes to stroke. So first of all, we usually educate people and the public on how to identify signs of stroke. And then once you've identified a patient and you feel like they're having stroke, you should immediately take them to the nearest facility. So in a setting where there's good ambulance coverage, so for instance in most urban centers, call an ambulance. But then in an area where you don't have ambulance coverage, just drive this patient to the nearest facility. The reason why time is very critical here is with every passing minute, billions of cells die out. So billions of nerve cells die out. And the aim is to prevent further damage. Yeah. And there are treatments which we can give that are very time specific. And we don't want to lose that window because the consequences can be very dramatic. Yeah.
Okay. And I think I attended one of your continued medical education sessions where you said that when someone is experiencing a stroke, each hour is equivalent to how many years of your brain cells? Was it?
So each hour is equivalent to aging by 3 weeks.
By 3 weeks.
By 3 weeks.
Okay.
Actually, with each minute, it's equivalent to aging by 3 weeks.
Okay. So each minute from the time you experience a stroke, you're losing 3 weeks of your life.
Correct.
Every minute. That translates to about 1 hour, 3 years. When you calculate that, that's crazy. What is the time window that people should aspire for?
So the soonest possible. We usually say that you have to be there earliest possible so that we can give clot busting therapies.
Okay.
And these clot busting therapies we only give to one type of stroke, the kind where we identify a clot or we think it could be due to a clot. But we cannot give it if someone has a bleed. The treatment for that is different. So what happens when these patients come to hospital, we'll do what is called a CT scan. And the CT scan will identify whether it's a bleed or not. Once we don't identify a bleed based on the CT scan, then we assume it's a clot. Because the very fact that time is of the essence here, we can't say let's confirm if it's a clot or not. So we just want to make sure that there is no bleed and we're good to go with the clot busting therapy. This therapy, we can only give it within the first 4.5 hours of someone getting a stroke. There are instances where we can give it beyond 4.5 hours and it requires more sophisticated tests and imaging and centers that have protocols that are suitable and systems in place to allow us to give this medication. Yeah, so that's why we tell patients, we tell relatives and families, bring your patient immediately to the facility. Once they arrive at the facility, make sure that this patient is seen by a doctor and preferably, if at all possible, even by a neurologist soonest possible, so that we can make a decision whether they are candidates for the clot busting therapy or not. And this saves life, it saves functionality, it makes a huge difference in terms of quality of life after the stroke.
From your practice, what are the most common conditions that are linked to stroke or associated with stroke, especially in the Kenyan or in the African population?
Now that is a very good question. So we have what we call the traditional risk factors. Hypertension, elevated blood sugars with diabetes, elevated cholesterol, which is also known as dyslipidemia. Those are the traditional risk factors that are associated with increased stroke. But in our setting, what we've discovered is that we're getting much younger people getting stroke without even having these underlying conditions. So some of the questions that we are trying to explore is what other risk factors are there that is driving the stroke prevalence and the increased number of strokes beyond the traditional risk factors. Some of the patients have autoimmune conditions. These are conditions where your body, instead of fighting off infections, ends up attacking the body's own systems, including the blood vessels, and it can cause strokes. Some of the other things we are seeing is that people have propensity to developing strokes, to developing clots, where the blood system is sort of overreacts. It forms clots very easily. And it can give you strokes. So we're also seeing that in young people who are coming with strokes. And the sad part, rather the scary thing, is that if you look at literature from the West, they call stroke in the young individuals who are having stroke under the age of 65. Yeah. Some countries employ an age cutoff of 55. We did a study in Nairobi, and what we found is that in our population, the age cutoff is early 40s.
Wow.
Yeah. Okay. And the other very interesting thing that is very well documented and published is that we also tend to see strokes in waves. And what has been discovered is that air pollution contributes to strokes. Okay. And it's one of the major risk factors for strokes.
Really?
Among the top 10 risk factors for strokes. Okay. Yeah. So environmental pollution is also a contributor.
Wow. Okay. Okay. I think we're all learning from this. Wow, that is quite interesting. And there's this quote-unquote myth that stroke is an old man's disease. I think you've handled it just a little bit, but I'd like you to just say it outright. Is it exclusively an old man's disease, or is it something that can also affect people in their early 20s and 30s?
Excellent question. You know, going through medical school, that's what I thought.
Me too.
Yeah, but then when I went into practice, what we've been seeing, especially in our setup, is totally different. We are seeing 30-year-olds with strokes, 20-year-olds with strokes, people who are perfectly okay, and then just one day you get a stroke and your life overturns completely. And some of the things that drive this include substance use and abuse. So especially amphetamines, you know, cocaine and things related to that have been associated with strokes. But we're also seeing strokes among patients with migraines. Okay. Migraine is a very common disorder, and I hope one day we'll talk more about this. Yeah. So a quarter of the world population have migraines. But then women with migraines, and the kind of migraines that give you warning signs before you get the headache, are at an increased risk of getting strokes, especially when they use hormonal therapy or contraceptives that have estrogen in them. You know, your combined pill that you take every 21 days or every 30 days, that significantly increases the chances of stroke in that group of people. And also there's a certain medication that we don't like giving to patients with migraine headaches called triptans, and that also has been associated with strokes, especially in patients with migraine that comes with the warning signs. And I think we can talk more about the migraines during another session. Yeah.
This was a common question among many people. How can families or people differentiate between a stroke and other things that might mimic a stroke, like a Bell's palsy? And it's interesting how people are also like confusing stroke with hypoglycemia or having a seizure, especially if it's an absent or a silent seizure. How can you differentiate that?
That's quite difficult, to be honest, and that's an excellent question. And the first thing, you know, when we get these patients with strokes at the hospital, we always check the blood sugar level, because it's a great mimicker for stroke. Yeah, and when we find low blood sugar levels, we correct it, and this person will walk out of the emergency room. But it's extremely difficult for non-medical people to make the difference. Yeah, so what I usually tell relatives, so if your relative has diabetes, they're on insulin therapy, most of the time they have a glucometer at home. So while you're waiting for the ambulance, you can quickly check the blood sugar levels, and if it's low, correct it. As if the patient is lucid, is still lucid and able to follow instructions. But if this patient is unconscious, you can actually cause what we call aspiration. So by trying to force feed them, it can go the wrong way and go to the lungs and actually cause more damage. Now, with regards to Bell's palsy, with Bell's palsy, also the mouth deviates to one side, and it happens suddenly most of the time. Some individuals might have a fever or a viral sort of illness that precedes it, or at the same time when having the Bell's palsy. But honestly, for non-medics, it's extremely difficult to make that distinction and differentiate. So my advice would be seek immediate care. Let's assume it's a stroke until we rule it otherwise.
In the same line of questioning, what's a transient ischemic attack? How can people differentiate between having a full-blown stroke and a transient ischemic attack? And do they need to take the same measures for a TIA as if it was a stroke?
Excellent question. So a transient ischemic attack, as the name suggests, is transient loss of a certain function. And it can manifest as weakness, where you lose power and the ability to move a limb, or it becomes heavy for a couple of minutes. And it can be as short as just 5 minutes. Or losing vision for a couple of minutes. It can be as short as, again, 5 minutes or less. Or even losing speech or the ability to speak very, very briefly. But the only way to objectively say that this is a transient ischemic attack and it's not a stroke is you have to come to the facility. We have to do imaging. So we have to do MRI. And if the MRI doesn't show anything, then we can say this was a transient ischemic attack and it was not a stroke.
And most of the time, the symptoms for a transient ischemic attack do not go past 24 hours. Am I right?
You're correct. That's, sort of the old literature. Nowadays, we are moving more to what we call tissue-based definition. So I need objective evidence that there is no damage in the brain for me to say it was a transient ischemic attack. And the whole concept of transient ischemic attack is that the blockage happened and it opened itself before causing a permanent damage. So there was no death in brain cells. But with stroke, there was damage.
For sure.
As small as it may be, the moment we do an MRI and it shows there was damage, we call it a stroke. Even if the symptoms just lasted for 3 minutes. And I have a story. Just the other day, and this is one of my relatives. She was in Mombasa. She was going on a walk with her husband, and then suddenly she could just not speak. And it only lasted 10 minutes, and then she was able to speak. She gave me a call. She couldn't explain what happened. I immediately told her, go to the hospital. She was seen by the neurologist there. They did the MRI, and she did have a stroke.
Wow.
So it can be very brief, and we need to take it very seriously, because you don't know next time or the second time, you might not be very lucky.
True. And once you experience a stroke, what are the chances that you'll experience another stroke?
Significantly high. Especially without treatment.
What are the long-term complications of stroke, and are the complications reversible or permanent?
Again, that's an excellent question. So we can look at it from a twofold perspective. And I like looking at it this way because contexts are different. In our context, the implications of stroke are phenomenal. Someone in their prime getting stroke and then getting disability from that stroke results in multi-generational poverty. There is good evidence to show that.
Up to 3 generations,
Up
I
to
believe
3
you said?
generations, at least 3 generations get subjected to poverty. So that's the economic impact of stroke and stroke-associated disability. Because we don't have the capacity to provide the care that these patients need after they get the stroke. But then in more developed countries, they do have the infrastructure and the support system. But still, stroke is one of the major causes of disability globally, regardless of where you are. Back to your question, what are the sort of biological complications of stroke? Loss of functional independence, requiring a chaperone and a caretaker to constantly care for you, take you to the bathroom, feed you, clothe you. You'll probably lose your job, and then families break down because you cannot attend to your marital needs, you cannot attend to your household needs, you cannot attend to your children's needs. These patients also suffer from depression. And we tend not to look for it aggressively, unfortunately. But most patients actually suffer what we call stroke dysphoria or stroke depression. And for various reasons, just suddenly you're unable to do what you used to do, and you're relying 100% on someone. Those are the most common complications and disabilities associated with stroke.
Okay. And are they reversible?
Yes. And that's a very tough question.
Yeah, I know.
And we get that question a lot from patients.
That's usually the first thing they ask.
Exactly.
Even the caregivers.
Yeah, so that's a very tough question. And what I say, it depends.
Okay.
So if you present to care early, chances of reversibility are high. There's a chance that when you get the right treatment at the right time, you come very early, you can go back to being normal 100%, like as if you never got the stroke. As in, walk out of the facility and maybe even ask yourself, what was all this hullabaloo, about stroke?
Wow.
But then on the other spectrum, there's a chance you can become locked in. So locked in means you have your retained faculties. You can hear, you can see, you can smell, you can sense, but you cannot communicate. You cannot react. Some people can only probably move their eyelids. Or you can have someone unable to talk, unable to move, bedbound. That's the other end of the spectrum. And it's also associated with increased mortality. Chances of death are extremely high after stroke, especially during the first week and the second week of stroke. The chances of death is extremely high.
Okay. What are the most effective rehabilitation treatments that someone can go for after a stroke? And as I'm saying this, there are hospitals that might not be able to provide for this, but the family can push for such, especially in private facilities and care. What do you advocate for people to do?
Great question. So when it comes to stroke treatment, we have what we call hyperacute treatment. So the treatment that we provide immediately when a patient presents with stroke. And that's a clot busting therapy. We admit them to ICU, we monitor the vitals, we keep them stable, we monitor for complications. I usually tell patients, probably this patient will be out of the woods after 2 weeks or after 10 days. Because once you get a stroke, the brain starts swelling, and we have to monitor for all that and treat it. And then there's a treatment called thrombectomy, where if someone has a clot obstructing the major blood vessels, then they can be sent into the cath lab and the clot is retrieved. And the good news is that we actually have that expertise and facility at the Moy Teaching and Referral Hospital, and also in another private hospital here within Eldoret. And that makes a ton of a difference. Now, after we've done all that, we have to rehabilitate these patients. And we have to make sure we prevent another stroke from happening. So we call that secondary management of stroke. So we take care of the blood pressure, take care of the sugars, we take care of any other cause that we identified was causing the stroke. Sometimes it's a cardiac problem, whether it's, and they have an abnormal rhythm that is causing the clot to form and causing the stroke. So we have to take care of that as well. Once we've addressed that as well, we need to release this individual back to the community. So that takes process and takes planning. So we have to do physiotherapy, occupational therapy, and speech therapy. So if someone has lost the ability to talk and communicate, then we have to work with our speech therapist to help them communicate and help them talk. And that is of paramount importance. One of the main challenges that we face is that we have very few speech therapists in the country, so they're really overstretched. When it comes to physiotherapy, we usually start it very early on, while the patient is still in hospital, sometimes even when they're still in ICU, and it makes a ton of a difference. Because the brain is a motherboard of wires. So what physiotherapy does, it helps retrain the wires, and the brain makes new connections. And this helps regain function that was lost to some degree. Occupational therapy they also come in on board because we must make sure you're safe. You're able to use the toilet in a safe manner. You're safe in your home environment when you're attempting to walk. So we don't want these patients to fall, get a fracture or get a head injury and come back with another problem. Yeah, so that's where occupational therapy comes in. And some of the more advanced rehabilitative therapy that hopefully we are still trying to develop is using like Botox injections. You know, so patients get what we call spasticity. They get a stroke and then the arm is fixed in this position. So we have to, you know, slowly release this, make the muscles that are tight weaker, and help with walking and allow this patient to use a walking aid. And it makes a big difference. Yeah. Some of the bottlenecks with that treatment is that Botox is expensive.
It is.
Yeah. And we have to administer it maybe every 3 months. Yeah. But it makes a very big difference in terms of functionality.
Wow. Okay. And I think I've also heard you mention that once you've experienced a stroke, your chances of getting another stroke are much higher. I think up to 4-fold higher as compared to the general public, right? So what are the lifestyle changes that one can take up to prevent a secondary stroke, right? And I think even with that, we can just have a broad discussion on how do you prevent stroke.
Excellent question, Dr. Biomdo. So first of all, we have to identify what caused the stroke in the first place, and address it. So often it's the traditional risk factors, elevated blood pressure, elevated blood cholesterol, and stroke or diabetes. So make sure that the diabetes is well controlled by giving the appropriate treatment, making sure the blood pressure is well controlled and within the target range where we want it to be. And making sure that the cholesterol is also well controlled and within a certain range where we want it to be. So you'll require regular follow-up with your neurologist and your physician, and if you have diabetes, maybe your diabetes doctor as well. And make sure that all this is cared for. And that significantly decreases the chances of getting another stroke. But if your stroke is as a result of your blood clotting easily and abnormally, then the treatment is different. We give you blood thinners. And you have to be on those blood thinners either for a specified duration of time or sometimes even lifelong. And your neurologist is the one who's going to tell you how long you're going to use those blood thinners. And so use your medications, be compliant to these medications, be compliant with regular follow-up. And other than that, simple things. Just lead a healthy lifestyle. So a healthy lifestyle involves eating healthy, lots of vegetables, lots of green leafy vegetables, healthy fruits in moderation, nuts in moderation, cooking with fat-free liquid oil, and also don't indulge too much. Don't have a lot of deep-fried meals. Eating lean meat, preferably having fish. Chicken without the skin, you know, lean chicken. And having frequent meals in small amounts, that also helps. Reduce your salt content. Don't stop it completely, but reduce it to acceptable levels. Exercise. And this can be very simple. Brisk walking for half an hour, 4 to 5 times a week. That's good enough. So I think if we go back to the simple things, that makes a ton of a difference. I'd like to pivot to another demographic of people, and that is the pregnant women. How do you prevent or lower your chances of experiencing a stroke as a pregnant woman? So, excellent question. So, pregnancy itself increases the chances. So, someone who is pregnant vis-a-vis someone who is not pregnant because of the hormonal changes. And, these hormones also increase the susceptibility to developing clots. So, we're usually extra vigilant when we see a pregnant woman presenting with a headache, a new onset headache. It gets us a little bit worried, and we have to figure out, why are you getting a headache that you never used to have before? Yeah. So we usually tell these people, seek care, let a neurologist see you, working together with your obstetrician. And we figure out exactly what's going on. Yes, sometimes you could be just having a flare of your migraines, but we have to make sure that there's nothing sinister, hiding and just waiting to flare out. But yes, we do see strokes in pregnant patients, pregnant individuals, and both hemorrhagic strokes. This is where the blood vessel just bursts and bleeds into the brain, and also ischemic strokes as well. And the way we care for it is slightly different. The principles are the same, but it becomes a bit complicated because we have to think about the fetus, and we also have to think about the mother. Yeah, and the treatments that we offer, the tests that we have to provide do have implications also to the developing fetus. So those are nuances that we have to navigate very carefully, working together with the obstetrician and talking constantly with the family and figuring out what's best for both of them.
Okay.
Yeah.
Now that you're talking about clots and in relation to pregnancy, I think we can also talk about that in relation to young people in their early 20s and 30s who we, in our population, especially here at MTRH, we tend to see a lot of cases of atrial fibrillation secondary to rheumatic heart disease in very young people, and some of them end up having strokes, and that is from their hearts. What do you have to say to the population? Because when I say this, we are in the era of where we're trying to fight antimicrobial resistance, right? But then at the same time, so we're telling our people that every time you experience a flu or a cold, it doesn't necessarily mean that you should take an antibiotics. But then at the same time, there's quote unquote cases of rheumatic heart disease that was secondary to acute rheumatic fever, that was secondary to a strep throat infection that, parents just ignored, which eventually leads to, as in it can lead to a stroke. Like, what do you have to say about that? And as I'm asking you this question, I realize that there's so many steps in between that are potentially beyond your control as a neurologist, because you have a cardiologist involved, the primary care providers, you have physicians involved, but what do you have to say? Yeah.
Excellent question. So yes, rheumatic heart disease is common in our setup, but the good thing is that yes, not all patients with strep throat infection will develop acute rheumatic fever.
Yeah, it's actually just 3 to 5%.
Yeah. So at least that reduces the numbers, but that 3 to 5% is also a significant number.
Sure.
And then among patients who develop acute rheumatic fever, not all of them will develop the valvular heart disease.
Sure.
But unfortunately, in our setup, since it's not recognized early, they end up developing that complication. And things are a bit better right now, actually significantly better right now. So MTRH offers valve surgery. We have a very robust cardiology program with cardiologists who are caring for these patients. And there's a lot of awareness about the complication associated with acute rheumatic fever, more specifically valvular heart disease.
Yeah.
So that has significantly reduced the complications that we see with rheumatic heart disease. Nonetheless, they still exist. And one of the major challenges is that, yes, these individuals will get a new valve, but they have to be on lifelong anticoagulation. And the kind of anticoagulation we provide is a drug called warfarin.
Yeah.
It thins the blood very well, but the problem is that we have to monitor. There's a lot of variation in how it works. So the diet that you take, if you take a lot of vegetables, it messes up how it works. So if you change your diet, it will mess up how it works. So we have to keep monitoring. And the good news is that at MTRH and UNpack, we have one of the largest anticoagulation programs in the world.
Wow.
Yeah. And very humble beginnings. It started off the parking lot of the hospital with a pharmacist going there to check, levels among patients, and then eventually, you know, one thing led to the other. A lot of philanthropy support, a lot of institutional support from the hospital and from the university as well. And we have a functioning program that is helping thousands of people. But that's a significant challenge, because if the medicine overworks, you can get a bleed. If it underworks, you get a clot. So it becomes a bit of a catch-22 situation, but we have a team of experts who are very well experienced in caring for this. So that's one of the biggest advantages that we have over here. The other side of it, I call it the influence of modernization, is that we are also seeing strokes in the young as a result of non-infectious causes. So young people, they want to party, you know, indulging in drugs, amphetamines. There's a time I saw one individual in his prime doing very well. I believe he was around 25 years old, and he had a massive stroke. Massive. Luckily for him, you know, he underwent thrombectomy, and he's doing very well currently. No disability whatsoever. But that stroke almost knocked out a quarter of his brain. It was massive. And he was open about it. Initially, he didn't disclose that he took cocaine, and it was his first time.
Wow.
Yeah. But then later on, he's like, okay, I did take it, and we detected it in urine. Yeah. So, yeah, these drugs can cause a massive, significant, you know, disability, and the consequences can be quite dire. Also, the other thing is smoking, shisha, vaping. Yeah. All these new trendy things, they have serious health consequences. So my message to the youth is that, yeah, just don't indulge. Yeah.
Okay. Yeah, I think that can be a very tough message to put across.
Yeah.
But I think it's good that people are educated and they get to know what they're getting themselves into, right? And what is the role of traditional remedies or herbal medication in the management of stroke? And with regards to that, how do you respectfully urge the population not, for example, go for the traditional remedies and seek science-based care?
That is a very good question. And honestly, as healthcare providers, we struggle a little bit. We actually struggle a lot, yeah, because patients believe that warming up the body will alleviate the symptoms. So you'll find, and the funny thing is that this cuts across cultures. It's sort of a universal concept, no matter where you are geographically. And there are some places where they would even pour hot water on patients. I remember there was once I was at a stroke conference, and there's this Middle Eastern professor who's a stroke specialist, talking about how he was shocked at receiving patients with stroke having burns. It's because the family thought that if they apply hot treatments, they'll make it better. So that doesn't work. Again, herbal remedies, we don't know what is contained in those herbs. They haven't gone through the rigor of science. And I tell my patients, just don't use any herbs. Because one, I don't think it's going to make any benefit. Actually, I can say confidently, not unless I have evidence to refute this, that it will not make any benefit. And on the other side, it will probably add additional harm. It might not go well with the medicines that we give. It might cause liver damage. We see a lot of liver damage as a result of herbal medications. Some people do very aggressive massage. The patients who've had rib fractures as a result of very aggressive massage and manipulation. You know, going to the chiropractor, and then they're like, oh, we need to crack your spine. And this has been described as a cause of stroke. We don't have a lot of data in our setting. We did contribute some evidence to a multi-site, multinational study, but I don't want to go into the details. It's something that we still need to investigate further, but there are reports that is very well documented where manipulation of the spine has been associated with strokes. So you get a dissection. So the blood vessel that goes to the brain gets stretched out, tears a little bit, and a clot forms there. Yeah.
Okay, and then it can lodge.
Yeah.
Go to the brain. When we're telling our patients to seek medical care as quickly as possible when they experience stroke, there's maybe an issue in between, especially with primary healthcare centers and clinics. There's a delay sometimes. Patients tell you that yes, they experienced a stroke, but they went to a primary clinic or just a small clinic nearby, and there were delays, right? By the time they're being referred to a level 6 facility like MTRH, where they can get the help they need by seeking care from neurologists and experts like you, there's so much time that has been lost in between. So how can you urge and advise these primary clinics to help in prevention and cure and treatment of stroke, and how can the policymakers, including the government, this, what policies can be passed to ensure that this, helps?
Great question, and it's really frustrating. And I'll tell you a story. Just the other day, I had this lady, amazing family, I was asked to come and see them. So I saw them 3 days after she had the stroke. And when I saw her, she had a severe stroke. Almost, one half of the brain, actually like a quarter of that brain was affected, knocked out. So she had lost her faculty to talk. She had one-sided weakness, and the mouth had deviated to one side. She could not feed. She was choking whenever they tried to feed her. So it was a severe stroke. But the frustrating thing is that the family actually took her to the nearest facility within 1 hour of symptom onset.
Okay.
But the facility that received her told them this is a mild stroke. They appropriately did a CT scan, but they did not offer the treatment that she required. And they kept her there for 2 days until the family felt like, we're not getting anything here, we're just getting IV fluids.
Yeah.
So let's go to Eldoret. And that's how they landed here. So she's improving gradually. We usually assess disability 3 months after the onset of the stroke. So I don't know what degree of disability she will have. It's not yet the 3 months. But now she's able to talk. And she has very good family support. And one of the toughest news that the family had to hear is that it's not mild stroke as they were told, it's severe stroke, and there's significant chance of disability.
What are the financial and social burdens of stroke from your experiencing managing these patients, not just in the short term, but long-term implications, and how can the government, NGOs, and other organizations support these people and their families?
That's a very good question. So, stroke is a major driver of disability globally. I believe, and we do have preliminary evidence locally to suggest that the impact is even much higher in our setting. One, it's because it's affecting individuals in their prime, individuals who are much younger, individuals who are expected to be productive in the community and contribute towards the economic development of the society and the country. And to make it worse, we are not prepared for them. So I think with help with the government and the Ministry of Health and all stakeholders involved, is that we should have a coordinated, concerted effort focusing on stroke prevention, stroke treatment, and stroke rehabilitation. And prevention, we do have very good mechanisms in place. I think as a country, we've done a tremendous job with HIV care, HIV prevention messaging, and we can use the same platform. We don't have to reinvent the wheel. We are experts. There's also a lot of efforts ongoing addressing hypertension, diabetes. We can just leverage the same, address the traditional risk factors, but we also need funding from the government and from research, national research institutes to support dedicated research in stroke and other neurological disorders. Because we have very little understanding of the other risk factors that are driving the stroke epidemic. I can comfortably call it an epidemic in our setting. And without that, I don't think we'll be able to come up with sustainable solutions or very impactful solutions. Yes, we address what we know, but we also have to discover what we do not know yet. The government and again all other stakeholders need to provide dedicated funding for infrastructure. Infrastructure for diagnosis of stroke, infrastructure for training all cadres to be prepared to handle a stroke, so that we have stroke-ready centers that are working in a coordinated fashion with referral centers such as the Moi Teaching and Referral Hospital. And we can offer expertise and support using a hub and spoke approach. And this has been demonstrated elsewhere in the world. So we don't have to reinvent the wheel. We just need to adapt it to our setting, but it needs funding. And the other thing is a lot of training, so that the public can know when their patients, their relatives are having stroke and refer them to care earlier on. But also more neurologists. We are very few. We are less than 20 the whole country. And in as much as we are few, we can work very well with other physicians and other specialists. We can work with cardiologists, we can work with internal medicine physicians, we can work with medical officers, clinicians and nurses in a concerted manner and make sure we are offering the right treatment to these patients. Stroke belongs to the neurologists. They're the ones who are driving the care, but we work with other specialists as well.
For sure.
Yeah, so if the government can also invest into more training for neurologists, that's the only sustainable way that we can be able to handle this epidemic. I don't want to sound like a pessimist or a prophet of doom, but we do have an epidemic and we are not prepared for it.
We do. I can attest to that. Just in my ward alone right now, I have around 3 or 4 female patients, and I can confidently say that all of them are below the age of 45 years who have experienced a stroke. So yeah, it is an epidemic for sure. I don't think I used to see that almost 8 years ago when I was in medical school. Yeah, so I agree. What is the role of infectious diseases like malaria, even HIV and other inflammatory conditions to contributing to the risk of stroke?
Excellent question. So different demographics have got different risk factors for stroke. Very interestingly, our colleagues in Zambia did a study, and they looked at the proportion of stroke patients who have HIV. And I know this does not confirm that HIV was the cause, but 21% of patients, so it was slightly above 20% of patients who had stroke, they were young, had HIV. And we know that HIV can cause inflammation in the blood vessels that results in stroke. Yeah. So there is good data. And I know there was another group that also looked into this. And interestingly, it is women with HIV in the reproductive age group who are at increased risk of getting strokes, maybe as a result of the HIV and the inflammation due to HIV, rather than women outside the reproductive age group. So, which makes us think, is it due to the hormonal influences? Yeah, so it's an area that is undergoing a lot of research currently, and we'll get to understand better. But as I mentioned, different demographics have got different risk factors, but that is a significant risk factor that we really need to look into. In terms of malaria, we know areas that have high malaria prevalence along the coast, along Lake Victoria. There's also increased cases of sickle cell disease. So one of the other causes of stroke is actually sickle cell disease. Malaria in itself can cause stroke. So when you have very severe malaria infection, it makes the blood thick, for lack of a better word. and increases the chances, of getting a clot, which would result in a stroke as well. The other, and this gets a little bit complicated, and I won't dive too much into it. So even infective endocarditis, the one that patients having a strep throat infection, and then they develop the complication associated with it that affects the valves of the heart, and then they develop now an infection of the valves of the heart. That has been associated with stroke. Call it sort of an infectious clot, or an infectious stroke. So you get development of clots that have infectious material inside, and then they get showered all over the brain. That one is a tricky area because the kind of treatments that we can offer are slightly different. We do not provide the clot busting therapy for those kind of strokes. Because it increases the chances of a bleed. So that's a bit of a tricky area. Luckily we don't see a lot of it, but it is there in our setting. The other area that I want to talk about are venous clots. So what I mean by stroke, all this time what I was talking about regarding stroke is clots in the arteries. But then the blood, the dirty blood, so to speak, that get drained out of the brain is drained by the veins. And you can get clots within the veins. And these are pretty common, like in pregnancy, immediately after delivering, it can happen. Interestingly, I saw a patient once who got a venous clot from herbal supplements.
Really?
Yeah.
Okay. There are no other risk factors?
No other risk factors.
Okay,
and
that's interesting.
Yeah, we did a very thorough exploration and very thorough testing. And she didn't have any other risk factors. And this herbal supplement actually contained plant-based estrogens.
Oh, okay. Now it's making sense. Okay.
So the hormonal effects increased the chances of getting a stroke in this patient. A venous clot. So we don't call it a stroke, we call it a venous clot. So cerebral venous sinus thrombosis is the medical name, but it can behave in a similar manner to a stroke.
There's this American singer, Danish Gambino, who experienced a stroke, I think, back in 2024. And I think for him it was a venous clot just because he had a hole in his heart. How common is that, and how can people watch out for such?
Good question. And, it reminds me again of another patient that I saw in 2024, actually. Young guy, unfortunately the outcome wasn't good. 35-year-old, he passed on. So this guy traveled from Europe to Kenya and then took a trip where he sat in a bus for 12 hours. And then when he got home, he developed a stroke. And then he presented to us a little bit late. So we weren't able to offer much, but it was within the window period where we could retrieve the clot. So we can retrieve the clot within 24 hours. If we feel that there is salvageable brain tissue based on some advanced imaging that we usually do. And he did have some brain tissue that could be salvaged. And this is why it's important, to take very detailed history from the family. Yes, we address the emergency situation, offer the urgent care that is provided, but we also take very detailed history from the family and from the relatives. And if the patient is able to talk, we also take very detailed history from the patient themselves. And that's when we were able to discover that he had long distance travel. Now, sitting down for prolonged periods of time increases your risk of getting a clot in the veins of the leg, because blood just sits there instead of moving. And we call that the second heart, because when you walk, it offers like a pumping mechanism and makes blood to flow. And sitting down or being static for a duration of
6 hours.
3 hours actually.
Really?
Yeah.
Oh, wow.
So imagine getting stuck in traffic in Nairobi somewhere. So 3
Every
hours.
single day.
Yep, is long enough. So it can give you a clot. And then the venous blood goes to the heart,
Yeah.
and then from the heart to the lungs,
Yeah.
and then it's cleaned, and then from the lungs it goes back to the heart, and the heart pumps it throughout the body. That's how you get clean blood in all the organs. But then what happens is that up to 10% of the whole world population, they have a hole in the heart that is very innocent. It just doesn't do anything. It sits there. But then there are certain individuals who have this hole in the heart, and they get a clot in the leg, and the clot moves. It goes to the heart. When it gets to the heart, it doesn't go to the lungs with the rest of the venous blood. It's transported directly to the artery through the hole.
Yeah.
And it goes, physics now, with the pumping system of the heart, it goes straight to the brain. And these clots are usually big, so the kind of strokes that they cause are catastrophic. Those are the kind of strokes where, hopefully, if they present in time, we have to remove the clot. It makes a ton of a difference.
Coming back to our setting, that is the Kenyan population, you've touched on removing the clot or thrombolysis. I realize that not many hospitals offer this service, but I believe as a neurologist, you offer these services. Where can people find you? Where can people find these services? And if someone experiences a stroke, can they come to you directly? And if so, where can they find you?
Great question. So I say stroke is the greatest equalizer, unfortunately. You're at the mercy of where you are, where you get it. So your insurance cover is as good as where you are when you get the stroke. So unfortunately, very few centers have the capacity to offer timely hyperacute treatment. So hyperacute treatment, as you mentioned, is the clot busting therapy, which we can only give within the first 4.5 hours. And in some situations, we can extend it up to 9 hours. The other therapy is removing the clot. And that kind of treatment is called thrombectomy. So lucky enough here in Eldoret, we have 2 centers that are able to offer both thrombolysis and thrombectomy, and they have the imaging infrastructure that will allow us to see whether these patients will benefit from these treatments, including extended hour treatments. The 9 hours for the clot busting therapy and the 24 hours for the clot retrieval treatment called thrombectomy. So MTRH is one of these centers. Eldoret Hospital also has a cath lab that can offer this. And again, there are several centers within the country that are able to offer this. Aga Khan University Hospital in Nairobi, they do offer both treatments. It's actually a JCIA accredited stroke center. I think the first one in Africa to get the JCIA accreditation for stroke. Hospitals in Mombasa, I'm not very sure of thrombectomy, whether they do have the capacity for it, but I know they can offer thrombolysis and clot busting therapy. So I don't want to talk about them because I might not be up to date with the developments that they've put in place. But in our setting here in Eldoret, we do have both therapies. We do have neurology expertise. So I'm primarily based at the Moi Teaching and Referral Hospital, but I can also see patients in the other facilities around. And we do have a very robust cardiology support service, renal support service, physiotherapy. We do have neurophysiotherapists who are specifically trained on neurophysiotherapy, and both of them are women. They're the first women in Kenya to be trained on neurophysiotherapy. PhD level education in neurophysiotherapy, both of them, so they're very, very well trained. Actually at par with international standards in advanced centers elsewhere in the world. So that's another advantage that we have. We also have speech therapy, so we can offer that as well. Yeah, so what I would tell patients is that the closer you are, and there's actually, again, evidence to show this, that the closer you are to a stroke-ready center or centers that are able to offer the services that are required, the higher the chances of a good outcome. Yeah. So if your relative, gets a stroke, bring them to Eldoret, get a neurologist. That makes a ton of a difference.
Yeah.
Don't waste time looking for a neurologist though, get a physician. So the first contact might be a physician, the first contact might be a clinical officer, a medical officer. That's good enough. And they should escalate by involving, the neurologist. We make sure that you do not have a bleed, that it is safe for us to offer these treatments, clot busting treatment, clot retrieval treatment, and that makes a ton of a difference. The worst thing is to see a patient where you think you might have been able to make a difference and then they present a little bit late. There's no words that can describe that. And unfortunately, we have to deal with this. But yeah, what I would tell the audience is that, yes, come look for me, and we are ready to offer the care that you are supposed to receive.
Debunking myths about stroke. Is it true that a lightning strike can cause a stroke?
Tough question, but the short answer is stroke happens like that. It's sudden onset. So I would understand why people would think that their relative who suffered a stroke got struck by lightning. But lightning strike, and I don't want to go into that, would cause an electric burn, which can affect the blood vessels and also cause a stroke. But that aside, strokes as we know it, they happen suddenly. And that's why relatives and many families think that this guy was struck by lightning and that's why he's how he is.
Okay, but in a nutshell, lightning strike does not cause a stroke?
It does not.
Okay. Okay. Do you have any ongoing programs with regards to stroke prevention, care, treatment, and rehabilitation? And can other stakeholders and organizations join? How can they come in to help strengthen what you have going on?
Yeah, thank you. Excellent question. And I think this is a call for action. So first of all, to answer your question, yes, we do. So we just recently partnered with Angels Initiative, and we have a very clear roadmap. We are working very closely with them to strengthen the stroke services at the institution and make sure that we are ready for all stroke patients when they come. In addition to that, MTRH, Moy University, the Moy University Clinical Research Center, AMPATH institution as well, have a very strong track record of community engagement, community research, community collaboration, and community trust. And this one has been built for more than 3 decades ago. And we work very closely with the community. All our activities are rooted through sustainability and through community support. And through that platform, we can be able to advocate for stroke. We can be able to educate the community about stroke. We can be able to inform the community where to go when their relatives and their loved ones get stroke. So that's the other advantage that we have at the Moy Teaching and Referral Hospital, Moy University and AMPATH. Secondly is that we have very strong collaborations with our collaborating institutions, our North American partners, that has been going on for decades. We've also hosted a number of NIH-based trials. So we're very well suited to also drive research in stroke. And we've been able to do very advanced studies in HIV/AIDS sphere, very advanced studies in TB, very advanced studies in oncology, very advanced studies in infectious diseases in general. And we do have the capacity to also do these studies and understand, the root causes of our problems in our context, within our clinical research center and within AMPATH and Moy University and MTRH as well. The other beauty of the medicine curriculum for Moy University is that from inception, it was built around community education, addressing community needs, and understanding the community that we serve. So that in itself provides again another platform which we can leverage for working together with the community. So I believe that we have the substrate, we have the foundation that can strongly support care, research, and education. Within Moy University, MTRH, Ampath, and the Clinical Research Center that we host. And this gives us an advantage. And I always say neurology is the last frontier. And it's not me saying this, many people say that neuroscience is the last frontier. But the advantage is that we can leverage on existing infrastructure and existing systems. And the time is nigh.
Sure.
Okay, you have a few questions.
No, that's good.
Ask. We're here for that.
So,
Yeah.
like, for example, I have my good friend on a seizure. So, I keep on a seizure, like, she struggles, like, she keeps quiet. Then another million, the person for some time, and then she's alone, at times there's a corner or two. But, like, it happens, evil.
Yeah.
So, like, in that state, there is no possibilities that one like your stroke, like, especially happen in between, because there's a stroke when you're breathing for some time, mama, so she should sleep for some time or something. So, is there many of the stroke and that's a different thing?
Is
So
that
it-
contributing factor?
Yeah, so strokes can cause a seizure. And it can be transient, meaning for a certain duration of time, or it can be for a long duration of time. Because what happens, the brain, just like every part of the body, when you get injured, it forms a scar. So that area that dies out and forms a scar becomes an area of short-circuiting, so to speak. So look at the brain as an electrical organ. And any area of short-circuiting can result in seizures. We do see seizures after a stroke, and we watch out for it, and we have to treat it. But seizures causing a stroke, not necessarily. But you can get, and this is a topic for another conversation, you can get patients who have frequent seizures, dying in bed. And we call that SUDEP, sudden unexpected death in epilepsy.
Thank you so much, Doc, for coming. We've really gained so much insight, not just for the audience, even for me as a medical doctor. There's so much I've learned from this session, including prevention, management, and long-term rehabilitation of stroke patients. And I hope that the audience, you have gained and learned something from this conversation. If you've not subscribed or followed, depending on where you're going to watch this video from, please do so. If you have any questions or inquiries, kindly do so on the comment section. And if you have more inquiries, you can click on the link in bio and send in your inquiries. As you've heard, if you experienced a stroke, or you think that there's anyone in your family member or a friend that you have is experiencing a stroke, get them to hospital as fast as you can. And if you can get access to a neurologist, here we have Dr. Jamil. He's a super specialist in his field. Please get them to a neurologist, or get them to a general physician. Then they can escalate to him. In that case, thank you so much for tuning in. I hope to see you in the next episode. Thank you and bye.